collaborate with as well. So this, I think we're getting a bit of background noise. If someone could, maybe if people could mute their microphones, please, that would be good. Thank you. So this is our 10th webinar that we've undertaken, and the topic of today's webinar is Chatbots and Health. That's the sort of general name. The more specific title is utilising passively collected data within daily life to enhance the assessment and digital treatment of mental health. And we're absolutely delighted that Dr. Nick Jacobson is giving the presentation today. And Nick is an assistant professor in those couple of departments listed there in the Giesel School of Medicine at Dartmouth College, USA. And Nick is also a close collaborator of Professor Bar Taylor from Stanford University and Palo Alto University, and Bar is one of our key collaborators for the CRE as well. So thank you, Bar, for introducing us to Nick. I think this is developing as a nice partnership and collaboration as well. And then our discussant for today's session after Nick's presentation is Professor Vasilis Kostakis, who's Professor of Human-Computer Interaction from Computing and Information Systems at the University of Melbourne, and Vas is also one of the chief investigators for the CRE. So that's enough of the introductions, and now Nick, I'll pass over to you. And once again, a huge thank you, Nick, for joining. Some of you might have heard as you were just coming on that where Nick is in the US, it's 1 a.m. in the morning. So we're really appreciative, Nick, that you've agreed to give this session. Thanks so much.
My pleasure.
I'll let you share now. I've unshared.
Absolutely. All right.
And you need to tell us what the view is behind you as well.
So this is Franz Joseph Glacier in New Zealand. I was visiting there just before the pandemic and keep reminiscing. Thanks for having me. And I am looking forward to talking to you all and hearing your thoughts. And Voss, I think it'll be a great chance to discuss again. So I'm going to be talking about a few different topics. My work broadly covers and spans the use of digital technology to assess and treat mental health problems. And so I'm going to be talking about a version of those things today. Let's see. My work is specifically focused on anxiety and depressive disorders. I'd like to give a background on this in case anybody isn't super aware or familiar with these. Anxiety and depressive disorders globally occur in about 1 in 5 people in any given year. They're the leading cause of disability worldwide, and they're associated with a pretty dramatic increase in all-cause mortality through chronic medical conditions. Our care system for treating these disorders is based primarily in one that doesn't scale well. About 4 in 5 people with a anxiety or depressive disorder don't receive what's minimally adequate care. Minimally adequate care here I'm talking about is any specialty care from a mental health care provider. So a psychologist, psychiatrist, social worker, counselor. One session in a given year would qualify as minimally adequate. And most folks really just aren't receiving that when they would have a diagnosis of an anxiety or depressive disorder in any given year. And globally, our care system within the mental health care world is just not built to scale well. We've got about one provider per 1,500 patients just with an anxiety or depressive disorder. That's globally. Regionally, even in high resource settings, it's not much different. I was in Center City, Boston 2 years ago, and we were, you know, in the largest hospital in the area, and we were running into the same issues, very long, over a year wait times, and so this is pretty common. You can view this as a glass half empty or glass half full problem, and I kind of view it both ways sometimes. And we have treatments that work for anxiety and depressive disorders. When so randomized controlled trials that through psychotherapy and psychotropic medications that can treat anxiety and depressive disorders. And our gold standard treatments for these disorders, after we would administer them, about half of people at the very end of the treatment that they're given still meet the diagnosis that they came in for. So about half of people are responding and about half of people aren't. And so we do have treatments that work, but they certainly don't work for everyone. And so yeah, I think we have a long way to go there. And part of why I think that is people present with anxiety and depressive disorders for different reasons and with very different symptom profiles. It's very heterogeneous. So that's just a background on some of the primary topics that I tend to focus on. Today I'm going to be talking about trying to enhance our assessment of anxiety and depressive disorders, primarily using technology, and then really trying to treat anxiety and depressive disorders through methods that do scale well. So I'm going to give you a primer on some of the things that I try to do in my work. I try to do something that's called multimodal assessment. That's a kind of a jargony word, but it's essentially trying to assess things with many different methods. And this is something that in psychology we've been looking for a long time. Folks have wanted to do behavioral observations of clinical phenomena for a really long time, and we have really historically relied on self-report data to try to capture, say, anxiety or depressive symptoms, because we don't have the access or resources to follow everyone around in their homes and try to see what's going on in their real lives. And there's some new ways to try to be able to do that a bit more with technology. So most of you probably have a smartphone next to you, or pretty in your close vicinity, would be my guess. The smartphones can capture a wide variety of things that are related to your everyday day-to-day life and functioning. So for example, just your accelerometer alone can capture your movement patterns. We can use the heart rate or capture your heart rate on the smartphone using a camera. We can try to detect when you're going to sleep and your sleep quality. We can try to capture your vocal tone, where you're going, every place that you little feedback you wouldn't mind me doing, I think that's great. So we can try to gather who you're around. So if you're nearby folks, if we're also can try to capture your emotions and your exposure to natural light in your day-to-day environment. This can give us a good sense of who you're, kind of where you are and who you're interacting with. A lot of different things there. So those things can then be used to try to understand, because those are related to our everyday behaviors and everyday functioning. My interests are really to try to use these methods that could be gathered in the background passively to gather information continuously over time in people's daily lives and see if we can understand them better. So one of the things that I'm interested in doing is to try to use this type of data to identify, try to predict who might have some kind of trait level difference. So trying to predict some kind of construct that's unchanging. So here, for example, we might be trying to predict someone's anxiety or depressive levels, or if they have a diagnosis of something. And then really the reason why we would try to do this with this passively collected data is really to try to see who might need treatment, for example. So these are static outcomes, things that wouldn't be expected to move in any close proximity to when we're making the prediction. So we've tried to do this within the context of mood disorders. So mood disorders being under the umbrella of major depressive disorder and bipolar disorder. And we used folks' movement across time. So their movement patterns based on, we gathered how they were, they extract a wearable sensor to the wrist for a few weeks. And while they were in treatment, they were essentially, we were tracking their movement across time, and we compared that to non-disordered controls. And try to see if we could use just the movement data alone, no information from them in any other way, just passively collected wearable movement data to try to, with some machine learning algorithms, to try to predict whether they were in fact of folks with a mood disorder or controls. You can see here the little blue guys are the ones that our models guessed right out of sample, and the red guys are the ones that our models guessed wrong. So these models are imperfect, but overall the sensitivity and specificity were good. The accuracy was pretty high. The kappa agreement, which is a metric often used in psychiatry, was about as good as iterators in a structured interview setting. So we actually thought we were doing pretty well here. We've done this in other domains to try to see if we could also predict not only the diagnosis, but also the symptom severity. So you can think about many different folks with a depressive disorder, a social anxiety disorder, for example. There's a range of symptom severity that exists, and folks to preclinical, so they might be impacted by the symptoms, but they're not quite meeting a criteria for a diagnosis, to on the very severe end, very extreme impairment compared to most people. On the left here, you can see our predicted depression scores among those with depressive symptoms, and these are in outpatient settings, trying to see if we could predict their depressive symptoms, also again using some movement data gathered in their daily life. And you can see that our little red line and our blue line there are pretty close to one another most of the time, and that's essentially suggesting that our models were actually doing quite well. They were predicting the majority of the variation and depressive symptoms, suggesting we can distinguish between not only if someone might have a mood disorder, but how depressed they might be. We can do some similar things in social anxiety disorder. This data was gathered not just with movement data from a wearable, but this was actually gathered via the phone. So we looked and gathered information on calls and text, and then used that to try to predict the degree to which folks might have social anxiety symptoms. And again, with using some machine learning models, we could do pretty well. This might be folks interesting to folks. I know many of you might have interest in behavioral medicine. Pain is often thought as a completely subjective experience, something that is best rated through like a subjective rating scale on a 0 to say 10 as metric is very common. We tried to see if we could predict this internal mental state that is supposed to be thought of as unmeasurable in some ways and subjective. And we, again, tried to do that through movement differences. So are people moving differently when they might have or might have greater pain intensity? And we did this in a sample of living with HIV. And overall, again, we could predict about half of the variation and pain among different folks that might be living with HIV based on movement data alone. And so this, again, suggesting that these kinds of signals might be really helpful in predicting symptom severity of a range of things. We've done this within the context of generalized anxiety disorder as well. So here so generalized anxiety disorder is essentially the summary for those who might not be familiar with it, is like pathological worrying. So it's worrying too much in an uncontrollable fashion about a range of things, and that it impacts your day-to-day life. And what we're generally showing here is, again, through some wearable movement data, our movement patterns, we've had pretty good sensitivity and specificity in detecting those who are at risk of developing generalized anxiety disorder. And you can see the patterns that our models were really picking up on were mostly feelings of restlessness and irritability, and feeling like one was going out of the mind with symptoms, so specific symptom profiles that were related to that. We've done this a range of mental health disorders. Another one we've done is try to distinguish between, we took a group of everyone who was exposed to trauma, and we wanted to see if we could differentiate between those who had PTSD. So actually, so post-traumatic stress disorder is not only exposure to a trauma, but then actually a great deal of symptom response that are delayed after that trauma. And so we wanted to see if we could differentiate between folks who might have PTSD from just those who might have experienced a trauma and not developed PTSD. And we could do that fairly well. And this is just based on their movement pattern, well, their location patterns and their day-to-day life. So where they move, how much they move, and how far away from the home, and how much time they spend. The dynamics related to that, we could kind of differentiate between those groups in a real way, and with decent sensitivity and specificity, suggesting that these things might be useful. So those were static outcomes. So we've also tried to do that, trying to predict some changes and things across time. So we've tried to do this predicting long-term changes. So here, a little bit further out, we could try to predict the changes in response to treatment for depression using wearable movement data. Again, we could do that in the context of those who were receiving treatment for depressive symptoms. And one of our more ambitious, I guess, in terms of our time trajectories, was we tried to see if we could predict the level in which people might deteriorate in their anxiety symptoms across a large age span. Across 17 to 18 years later, try to see if those anxiety symptoms might be increasing across time, and try to predict that through, again, wearable movement data. And here our performance was a lot worse than we might have hoped. So our sensitivity was pretty okay. Our specificity, on the other hand, was not so great. And so essentially our models were a lot better than chance, but not what we would want if we were going to implement this in like a clinically actionable setting where this was the only information we were relying on, for example. But this did a lot better than self-report measures, which really had a sensitivity and specificity of about 0.5, or sorry, about 50%, if we think about it that way. So we've also tried to predict rapid symptom changes, and this is where I'm kind of getting to the treatment end that I'll talk about. I think this is where things pair quite well. So we've developed apps. So I've developed a couple of apps for these kinds of things, and one of the ways that we try to do that is to use it as an intervention for anxiety and depression. So this one of the apps, we will collect information on folks to try to understand their anxiety and depressive symptoms within the context of their day-to-day life, and then we will give them feedback on that. We've collected data with these applications from folks around the globe. So some for those joining from Australia, I collected some from some folks in your neck of the woods, but across over 100 countries, and really, with a little over 10,000 folks here. Yeah, just has been kind of used and deployed in several ways. We've tried to use this to understand the rapid changes in symptoms across time. So one of the things that our psychiatric interviews don't often really capture when we're trying to assess these things is that they change a lot over time. So I was just talking to somebody with major depressive disorder for a study actually about 7 hours ago. And I was doing a psychiatric interview and they were telling me about their day, and their affect changes within the day pretty rapidly and across days pretty substantially. And these rapid symptom changes are characteristic of both depressive disorders and anxiety disorders. Actually, most mental health problems that I've seen that have an emotional component to them, I tend to see this in data. And you can see that on that bottom x-axis here, we're trying to predict that change in their depressive symptoms across hours. So here, it's across a single week, and so you can see how much these symptoms can be fluctuating across time. And you can see our models predicted, the red lines and the blue lines were pretty close. This was from the mood triggers application. And so we were having folks log their depressive symptoms once an hour for every hour that they're awake, and trying to predict their changes in their depressive symptoms using calls, texts, and movement, heart rate, location, and exposure delay. You might be interested in, so like what I keep alluding to, these sources of information, like what's maybe a driver of a signal of these kinds of things in terms of some of their behavioral signals. We've used this, and I'm going to show you one of the studies. Within depression, it's very heterogeneous. A lot of folks might have different signals of depressive symptoms, and I think that's part of the challenge. In anxiety, we were trying to do something similar with the mood triggers application, and we found a really strong signal of momentary changes in folks' anxiety and avoidance symptoms, which is a hallmark symptom of anxiety disorders that will often really be a big part of the maintenance of anxiety disorders, is avoiding things within the context of daily life. We found that we could get a pretty good proxy of that using whether they were indoors or outdoors, based on some of the sensor data. So essentially how accurate our GPS radius was. So when your GPS is trying to obtain a lock, it's having a hard time, you can have a good sense of whether you're indoors or outdoors. And these kinds of things are essentially, we're very strong predictors of anxiety and avoidance symptoms and their fluctuations within the context of day-to-day life and from hour to hour in folks with anxiety disorders. So what does all this suggest on the assessment side? To me, it suggests that we can collect information unobtrusively within the context of daily life to accurately assess psychopathology with little burden, right? So this is these types of sensor data and information really are captured in the background without having to ask folks a bunch about their symptoms. All right, so delivering, so then the next part of my talk is really going to be talking about and translating that into some kind of scalable, personalized treatment that could be delivered digitally. So with Bar and some other folks on the call, I worked with folks on some technology-based treatments, also for generalized anxiety disorder, which is, again, this pathological worrying, and tried to see if these treatments are effective in folks' day-to-day life, finding some good signals that in some randomized controlled trials across multiple sites in the United States, and then a few sites in India, that these treatments can seem to work within the context of daily life. Going back to one of the applications that I developed, one of the ways that it can work as a treatment is to engage with symptom monitoring. So where we ask folks about their anxiety and depressive symptoms hour to hour, and how it might look would be they might receive a notification, get pinged, and then we'd ask them to complete some reports on their anxiety and depressive symptoms. We'd ask them about a lot of different components that are theoretically thought to maintain those symptoms. So things like, did they have a negative event imminently? Or are they feeling helpless or hopeless? Were they engaging in avoidance behaviors? Were they feeling fatigued? And we captured their heart rate using the camera. We also did the passive sensing, like I had mentioned. But one of the ways that we captured, these sensors in the background, and then we would try to analyze that data for them. So we'd have this information on their daily lives, and we would have information on their symptom ratings across time. And one of the things that we were trying to do with this application was to give them personalized feedback based on the data we had, what might predict their changes in their depressive symptoms. So folks might have installed this application looking for more information about what was going on with them. And so, for example, they might find that negative events and the reaction to it were some of the biggest contributors to their depressive symptoms. And that might be different from other folks who might experience more fatigue, for example, and that these kinds of things we were hoping would be some kind of knowledge or insight that might help them to understand their depressive symptoms better. Within an open trial of about over 10,000 folks, we found that anxiety and depressive symptoms tended to decrease significantly with decently large effect sizes over just a 1-week interval. So pretty sharp changes in anxiety and depressive disorders. But we haven't tested this in a randomized control trial, this particular app in a randomized control trial yet, but that's going to be forthcoming. So just more generally, I'm going to back up and kind of then start gearing into what Brian alluded to at the beginning, which is chatbots. Chatbots were developed as in large response because the digital therapeutics are really, one of their big limitations is engagement. So they are a scalable option that can really scale to the large number of folks that might need them with little barriers. They have strong efficacy, at least across a number of different trials, both within my group and there's so many folks that are doing this work, some on this call that are just absolutely fantastic superstars. But one of the big problems that with these kinds of approaches are they're limited by engagement. So by engagement, I mean like actually using them, continued use across time. So you can see some engagement patterns of how long people use the PTSD coach here on the right. So how these kinds of, one mechanism to try to change this was taking how this field in some ways, one way of thinking about how it evolved was in-person treatment manuals where psychotherapists were trained with protocolized psychotherapy. So essentially trying to tell them how to treat what, session by session guides and things like that of what they're trying to focus on were translated into websites. These websites were tried to provide a lot of the same information to folks directly through large blocks of text early on, and they were a little bit less than accessible in terms of actually breaking things down in ways that might be digestible. And so chatbots are essentially have been developed to break some of the large amount of content that was down into a small bite-sized way. So an interaction, so in a small chat portal where folks could essentially actually type in and respond to something. And so this would be like a structured program, but breaking a large amount of information into a small amount of bite-sized information that could be prompted via some kind of natural chat interface. The chatbots that have been developed in recent years and have mostly been authored chatbots, so they're designed ahead of time. The person who creates the chatbots has to sit down and write everything ahead of time that the chatbot will say, and you might have some options about if they say yes or no to my question here will go kind of slightly differently, but it's generally one pipeline. So everybody goes generally through the same, they get asked maybe the same questions, they get told the same thing. They're not really responsive and they're not really chat-like. So a lot of the idea of what these authored chatbots are is they're supposed to be these conversational agents, so things that you could converse with naturally, ideally. But if you don't anticipate everything that somebody might say, which I think you're probably you're not going to be able to do, it can be very challenging. So we've tried to develop some large-scale language models that can approach these problems. I'm going to skip some of the methods because I think we're getting a little tight on time, and I want to make sure we have room for discussion. But we've tried to deploy these and train these models on essentially based on some machine learning and deep learning algorithms on a large amount of different types of data. Some data that were contained with mental health forums, hoping that folks might have some peer support and we might be able to pick up on peer patterns. That did not work well. We tried that within the context of psychotherapy transcripts to pick up all the bad habits of the psychotherapist, go on, and then some kind of extrapolations sometimes because we had some, I don't know, some not so stellar examples of things when we were training this with thousands of psychotherapy transcripts. And we really then developed the idea that these models needed to learn how to speak to another human through through generated expert content. And here, these models are able to essentially produce language in ways that could imitate a human, and we try to treat them similarly to how we'd actually train a psychotherapist, giving them examples to learn from of what good therapy might look like, exposing them to the basic theoretical rationales of why we do what we do when we would be treating something. And then we've been trying to then give it these examples and then deploy it in the real world. I'll skip that. Skip this over time. Overall, we've taken an inventory on this. This is still early days for this chatbot work, but overall, we've seen dramatic increases in kind of the clinical appropriateness of the responses that these models are generating. And so again, because we're not telling it what to say, it says its own thing. It could say like literally anything. And here's an example of kind of what the chat interface looks like and some responses to and from it, from the chatbot. This is from, I think maybe, what was it, a week ago, of when I was interacting with it. And so here, I came into the chatbot and told the chatbot that I was feeling really depressed lately. It responded, "Hi, that sounds really difficult. Can you tell me a bit more about why you're feeling depressed?" I said, "I haven't been feeling like myself lately. I don't know what the point of everything is. I just keep thinking that life is pointless." And it says, "It sounds like these thoughts are really impacting your life. How long have these thoughts been going on?" You can see it's kind of gathering the context of what I'm saying and actually responding to what I'm saying. If I had said something about my anxiety symptoms or something else, it would have responded to those. We have not told it these exact messages to say before. It's actually like being able to pick up on the semantic relationships of things in a way that can respond to folks in the moment, as might kind of be mimicking of a human provider. So a lot of my work is essentially trying to pair the two. So I talked about kind of two different things, like this passive sensing stuff and this treatment side stuff. A lot of what I'm hoping to do within the context of the grand scheme of my work is to pair the two together, is to try to collect information about folks intensively in their daily life, gather some data about them within their daily life based on sensors, run some personalized models to try to predict what intervention might be, we should initiate with them, select the targets of the intervention. So should we treat a specific symptom of their anxiety or depressive disorders, for example, select the intervention, deliver the intervention, try to treat some kind of near short-term outcome, and then hope that that has an impact on the distal outcome, and then study that as well. So those are generally the things that I'm working on right now, and kind of will be working on in the long-term future. Some of these things are underway, some of them are to come. But that's the gist of my work, a lot of the things that I care about. I want to thank folks in my lab, my collaborators as well, that have made all this work possible. And I'm happy to talk with you all about anything here, or hear Vas, your thoughts.
Thanks. Thanks so much, Nick. And there's already a few questions in the chat, but before coming to those, let's hear some reflections and comments from Vas. Over to you, Vas.
Hi, can you hear me, Nick? Great. It's always great listening to your talk, and I have to say it's one of the rare occasions where I feel the work is has depth and breadth. And I think it's great that you bring it together, you're doing work on figuring out what's going on with people and then doing something about it. And we get to see all of that in one talk. And I guess your final slide was that diagram you had was very interesting, just to get an understanding in your head of how the different pieces of the puzzle fit together. So this kind of work is becoming more and more popular, right? This passive sensing or digital phenotyping, where we realize that we can get a lot of data about people's behavior, and then we just get some more data about some specific phenomenon we're interested in, or some particular behavior with more reliable data. We try to put the two together and see, if we can establish relationships or correlations. And I see this recipe applied to all kinds of problems with kind of interesting success. What I've recently realized is that when I ask people why they're doing it, I get different answers. So although everyone's doing the same thing, I realize that they have different motivations for this. So I wanted to ask you, why do you do this kind of work? So why do you think a phone or this kind of automated passive sensing is a good idea for the kind of problem you're working on? Why not ask people, directly?
Yeah. The big thing, I guess, ultimately for me is one of practicality, like in utility. So can we predict it? Great. Why? What would we want to do with it? And why? So really the goal of this is, I mentioned how much people change across time in their symptoms, throughout the day. That's actually the majority of the change that occurs within folks is within days. And so a lot of that to gather that and intervene in the moment would be intensively burdensome. So if we wanted to trigger some kind of intervention in those moments because of how they were changing in their symptoms, we'd have to through kind of our more traditional methods, we ask them, right? And if we're almost constantly asking someone, our participants that are participating in these studies don't like these studies all that much, in large part because we're asking them so many questions so often that it's pretty burdensome. We have to actually give them some decent compensation along the way so that they are incentivized to do it. Otherwise, it's a lot of questions to ask about our symptom changes so often. And so I think that's a lot of my interest, is to focus on functionally kind of doing something that would normally be a very heavy burden, and trying to ameliorate that by actually just kind of seeing if we can develop a model that could do that without that, but could still be responsive in the moment. So trying to predict something that these rapid symptom changes and trying to treat them as they arise. So a lot of practice, there are so many different models of care, and psychotherapy has probably got one of the most kind of in the moment responses with folks, but we're seeing folks maybe once a week is probably among the most frequent in outpatient settings is a pretty typical model. And those folks we're seeing for about an hour a week. And so like, we're not really meeting them where they're living most of their life or understanding and intervening in their life most of the time. So this is really trying to kind of see if we can understand when we should be delivering an intervention without making a huge muck of a burden with all of it is the goal of it.
Right. Now I wanted to ask you to take us behind the scenes a bit of your research. I'm still kind of talking about the first part, the sensing. And my observation is I noticed even in your talk, when you're doing an online study or, a chatbot study, you get lots of participants. When you do this sensing study, suddenly you drop to double digits. And this seems to be a pattern I've observed again. I wonder how you feel about these smaller samples. Are they big enough? Is it just too hard to get big samples,
Yeah, how to marry the two. So I guess when we're thinking about things, one of the things with like the sample size that determines it is really the incentive structure for it. With a lot of our passive work, I'm honestly focused on things that are methods that can be deployed within a single person. So because I'm running personalized models often, or I'm interested in personalized models, some of the work, a good amount of the work I actually showed could incorporate the group patterns, but these methods can be generalized to a single person. And you could be powered sufficiently to try to detect whether there is substantial changes in that person. And if the models can pick up on signals, which they can on the person, part of why I do that is because of focusing on the sheer amount of heterogeneity between folks. So like folks are really different from one another, and because of that, I try to focus and deploy on these personalized models, like really specific to that individual. So here at when I think about sample size here, I think about domains of generalization more than I think about power or something along those lines. And when I would be publishing or collecting data, I would want to make sure that we don't have some kind of really strange sample or something like that where we could predict it, but it's in a really unusual scenario of individuals. So we're often thinking about trying to collect a decent amount of data to try to see how many people it might generalize to, and is that sample representative? Obviously, the larger you get, the bigger it is, but I think it's a little bit of a different conversation than folks might often ask about, in large part because we're actually collecting large amounts of data from these individuals. So like our small samples, for example, are some of the work I was talking about, the passive sensing data deployed in the context of within these hour-to-hour symptom changes. We're trying to predict like several thousand data points of their mood changes. It's just across 30 people, but it's like actually so intensive that we have a decent amount of data within that smaller group of folks.
It's very, very useful to know your strategy around presenting this work and how to convince reviewers. I think you can all learn from that. So I will ask one final question, and then I'll go through the questions in the chat and invite others as well. I'm just thinking about the chatbots and that kind of body as a means to intervene or provide treatment, ongoing treatment that's scalable, etc. And I really like the analogy where you say, a human can only see a patient 1 hour a week. Maybe if we digitize and automate in some way, we can provide more treatment. And I think when you go down that route, in addition to getting more face time or interaction time with the patient, you also get more insights about the person. So here's my question. I mean, I guess chatbots need to get trained on a data set so they're kind of ready when they face the individual user. And they might actually get trained or improve as they interact with a particular user. They learn the user's habits, for example. They might remember their previous history of conversation with the user. But my question is, do you think they could also benefit from the passive sensing, not in the sense that they know when to interrupt you, but they know what your interests are, where you've been. They could strike conversations about things you're doing. And in a sense, it's almost like having you know, a little angel or devil sitting over your shoulder, looking at what you're doing and then telling you, did you really think about that? You know, how do you feel about that?
I think it's a fascinating question. I think that I have like some actual practical ideas about how to implement that. I have a very big interest in kind of, yeah, facilitating these kinds of interventions in that way. I think it is possible, and I think there's some, I don't know, I have some hope that that would work. That work is so yet to come for me in terms of that happening, but I think there's a real practical advantage of that if the chatbot understands like the context within your daily life more than anything that would be just textually entered. It can gather things more like, honestly, a human would. If we're focusing on folks in a human conversation, we're incorporating other sources of information that we have on a person. And so like the chatbot really, if it incorporated contextual information, would be more like a human following someone around in their daily life, integrating. So yeah, I think it's a wonderful idea. I do have some thoughts about that. That is some of my own vision as well, and I think it's fantastic you like have these same, like I think you've got a lot of the same ideas. I think it's going to take a whole community to figure these things out. So yeah, it's exciting ideas, and I do have some hope that this could be really practical in the future.
Right. Okay, so Brian, you said that there's a lot of questions here. How do you want to handle them? I'm happy to sort of try and pick some to discuss further.
Yeah. Well, I think let's try that. I just sense that maybe we're just beginning to scratch the surface with your comments and questions and some of these, and maybe there would be interest in having a kind of follow-up dialogue and also thinking about, certainly in my mind, I'm thinking about the applicability of this work to other kinds of health conditions as well, you know, managing chronic conditions, other kinds of sensing, measurement and blood glucose monitoring and so on as well. So I think there's lots of other applications that we could talk about beyond the mental health field. But why don't we go through some of the questions and get brief responses from Nick and see how far we get. And if people could indicate if they'd be interested in a follow-up session on this topic as well.
All right, so let me start with one I think that's quite interesting. I'm actually working myself from the bottom up. So we've talked a lot about, you know, automating things, but still, you know, we need to think about how technology like this would be integrated with health services, and how would you actually make perhaps even better use of that one precious hour of time you get with a human, you know? So how do you see these things integrating?
I guess I think of a stepped care model when I think about the implementation of these tools. And the stepped care model is broadly that there can be different tiers of care that folks might need access to. I think given the number of providers out there, I think there has to be some option that cannot rely on access and integration within the healthcare system. It's a fairly large barrier for too many folks. So a lot of my work is trying to go direct to consumer and kind of go outside of a care system. That being said, I think that digital therapeutics have a huge potential value to be integrated within the context of daily life and within the context of traditional care. I certainly think that traditional care can and will be superior to these things. Essentially the idea for me is not to like replace it, but to offer something when somebody would normally have nothing. And so like I do think that these kinds of methods could be enhanced. I think like within the context of say a chatbot, there's a lot of nuances that I think might come up. And some of these is like for example, when you would be seeing a provider, often people are encouraged not to see multiple psychotherapists at the same time because you might receive conflicting information and there's disagreements and theoretical rationales. So like, for example, with a chatbot, if you wanted to have like a cohesive treatment team, it would be important that they were on the same adopting like the same theoretical approach to treating the same things. Like there are some practical issues that really come up that I think would really be important in aligning a digital therapeutic with providers. But Bar and other folks on these calls have done these kinds of work integrating care within traditional psychotherapy, and I have really shown some promising data on that as alleviating burden, lowering costs. I think that there's definitely a lot of really strong work in that area. That I think as we get into different areas, there are some complicated factors that can arise, and try to build those together.
Okay, and from the patient's or participant's perspective, have they raised, without getting, it's a whole kind of worms, privacy? I mean, has this issue come up, and what other issues have come up from participants' perspectives?
Yeah, privacy is the biggest concern that comes up. And the App Store, we really pretty much all of the negative ratings that we got were related to privacy issues because people had concerns. And I get it. I mean, we're collecting a lot of information about folks' daily life and able to reconstruct it in real ways. To me, I guess a big part of this for us is trying to make sure that people understand what type of data we're going to be collecting and what we're going to do with it. And if they're okay with then after they actually do understand that with proceeding, then I think that's kind of really where I see things, is trying to make sure that they do understand the choices and the kind of data that we are collecting, and trying to actually work with our IRB to make sure that we, when folks are giving informed consent, that it's accessible and it's not just like a long terms of service. That's kind of I don't know, been a fight, honestly, with trying to make sure that it's not presented in legalese for them. But yeah, it's something that I do care about. And yeah, I think it's a big issue. Particularly, I'm a little less concerned necessarily about privacy in research settings, given the amount of oversight that folks might have with institutional review boards. I think in private industry settings, this can be a really big deal, where folks' data might be sold or something along those lines to marketers or providers that way. That's happening right now. And I think folks are often very much not aware of it happening based on the way that it's asked. And so I think there's a lot that can be done with these types of data, and from different providers, it raises really some sticky situations. So I do think what folks are doing with the data is very important.
And so again, sticking with participants, one question is about dropout rates. So have you had, have you faced high dropout rates, or have you done anything to reduce dropout rates in your studies?
It really varies on the study, but yeah, it does occur. So one of the things that we do to try to enhance dropout is actually pay folks. So that really the dropout rate and the compensation rate are pretty tied together, unfortunately. So when particularly, I guess the dropout rate for when we're doing these really like frequent asking of active monitoring, that's where the dropout rate is really high. When we're doing things that are less frequent, so like when I was talking about the long-term changes or the static changes, or the static kind of symptoms, those kind of tend to be much higher compliance because they're easy to do. They're collected mostly in the background with some structured interviews or some survey data or things like that. The burden generally is less than, but as we're looking at something that we would kind of ask people about their symptoms across time, several times a day, then yeah, it becomes burdensome. And if we don't pay folks a good amount of money, it can be hard to keep them enrolled and active and participating because they don't have much incentive to do so.
Okay, well, thanks, Nick. I could chat with you for days without stop. This is really interesting. Thank you so much for the presentation. Brian, I'll pass it over to you.
Thanks so much, Vas. Could people, with their reactions, indicate if they'd like to have a follow-up session on this topic? I think Vas has already voted with his comments and nodding his head. So people want to have a follow-up session on this?
Maybe not at 1 a.m. for Nick again.
Yeah.
Oh, that might be preferable, but that's okay. It's been fun. I definitely enjoyed it.
Okay, well, I think probably third to half of people indicated. So I think we've actually got a blank slot for the next month, which is 4 weeks from today. So I think it could be good to have a follow-up session, and we can broaden it out to other health applications in addition to mental health. I'm sure Barb was champing at the bit to talk about some of his other studies as well. And then I think coming back to Joanne's question about how to really use this kind of model or approach in sort of real world healthcare delivery beyond the research world, you know, where people aren't being paid to participate and so on, I think is an interesting question of what the incentives would be. So yep, so we'll watch this space. We'll definitely have a follow-up session, and thank you so much, Nick, and we ought to let you go off to bed now if you're not too hyper. Thank you. Big round of applause from all of us. Thank you. And thanks Vas, and thanks Dom for facilitating behind the scenes and recording and so on. Thanks everybody. See you next month. Bye-bye. Bye-bye.